Good morning. My name is Flavio Rocha. I am a surgical oncologist at Oregon Health and Science University in Portland, Oregon, in the United States. It's my distinct pleasure to be here today with you virtually. And I'd like to thank Dr. Wasim and the organizing committee for the invitation. We will be talking today about molecular profiling in biliary tract cancer. So as a surgeon, I'm always thinking about principles of local therapy. And I think we all want to cure disease when it's amenable to resection. However, if it's locally unresectable, is there a way for us to control disease progression and preserve liver function, particularly in cholangiocarcinoma? Or are we able to palliate symptoms in the presence of metastatic disease when it's unresponsive to other therapies? Here are the local therapies that we have for intrahepatic cholangiocarcinoma. Of course, resection is the standard of care, while transplant is being considered as an experimental option. When amenable, these tumors can be directly ablated by radiofrequency, microwave, or irreversible electroporation. But of course, there's many catheter-based hepatic artery-directed therapies, including transarterial chemoembolization, selective internal radiation therapy with agents such as Y90, and what I'll be talking about a little bit today, which is hepatic artery infusion pump, or HAIP. In addition, radiation can be administered externally through external beam, SBRT, or even protons. So let's talk about the importance of resection and when it can be indicated. So when you look at this large series from Memorial Sloan Kettering in New York, you can see that out of 238 patients with a primary tumor, only 46% were actually explored, and only 77 actually underwent a potentially curative resection, meaning that only about 1/3 of patients can present with surgically curable disease. When we actually look at these resected patients, again from the same study, you can see that despite resection, 62% recurred at a median of 26 months. This was 47% in patients with solitary tumors and no lymph nodes, but was nearly universal in patients with multifocal disease or positive lymph nodes. Interestingly, 63% of the recurrences involved the liver, and there were several predictors of worse outcomes, including the number and size of tumors, vascular invasion, positive lymph nodes, and the need for a bile duct resection. But this was in 2008. Now in 2024, do we have other ways to predict and actually choose which therapies to give patients? And this is where molecular markers come into play. So if you look at the current landscape of biliary tract cancers, you can see that there is almost a signature, and there's different mutations that can be seen, depending on whether the tumor is extrahepatic or even gallbladder cancer. In intrahepatic cholangiocarcinoma, for example, we see the highest rate of actionable mutations, with FGFR 1 to 3 fusions, mutations, and amplifications, as well as IDH1 and 2 mutations in a majority of patients. Therefore, I would argue that mutations matter. If you look at this other early study, you can really see how, in tabular form, you can see the differences between these biliary tract cancers. Again, we covered the ones in intrahepatic cholangiocarcinoma, but in extrahepatic and gallbladder cancer, for example, you see a higher incidence of ERBB2 amplifications or HER2. So why does this matter? So when we look at this prospective study, again, out of Sloan Kettering as well as Washington University in St. Louis, you can see that patients were treated with hepatic arterial infusion therapy actually had a pretty enviable survival, and these were patients that were unresectable. So we actually had patients that had an 84% disease control rate, even 4 patients that were converted to resection, and 1 with a path CR. The median survival in the entire cohort was 25 months, and the 1-year survival was 90%. But when you break down by mutation type, you can see that the IDH mutants actually had a survival of 90% at 2 years, compared to 33% in the IDH wild types. This was just an exploratory finding, but certainly was more fodder for discussion. So this group then looked retrospectively at their patients that had cholangiocarcinoma, now with lymph node metastases, and looked at the role of resection versus pump therapy. And you can see here in lymph node negative disease, resection appeared to be associated with better survival compared to systemic disease or hepatic artery pumps. But when you look at node positive disease, that benefit seems to go away, whereas pump therapy and resection are equivalent in survival. Looking further again at node positive patients, the IDH status now becomes insignificant, whether wild type or mutant. again, in patients with node-positive disease who had hepatic artery infusion therapy. But they were actually able to identify a high-risk signature with mutations in KRAS, P53, and CDKN2AB deletions. So these patients, despite aggressive therapy, did not do well. Here at Oregon Health and Science, we actually do use hepatic artery infusion therapy, and Dr. Mayo, one of my colleagues, has recently presented this trial at ASCO and is currently being written for publication. So this is the same population of patients, unresectable intrahepatic cholangiocarcinoma, who had induction FOLFIRINOX and then hepatic artery infusion with FUDR. You can see the protocol is quite extensive with several correlative studies. And I don't expect you to read the whole poster, but I want you to identify what we found. So out of 9 patients that were screened for eligibility, 5 were ultimately enrolled and completed the trial. I'll take your attention to the far right, where you can see the patients now. You can see how far out they actually are in therapy. So patient number 1 is 28 months in therapy on HAI only. And as you see, patient 5 is up to 15 months so far. The purpose of this trial was to really demonstrate feasibility of this approach, which it certainly has. And so the question is, where do we go forward with this? I think another very interesting paradigm has been the application of neoadjuvant chemotherapy, again, for intrahepatic cholangiocarcinoma. You can see here in this retrospective French study, the combination of chemotherapy preoperatively and surgery was associated with the best outcome. But what agents to use? Well, recently, the GAP regimen, which was gemcitabine, cisplatin, and nab-paclitaxel, did show promise in a phase 2 trial, whereas 12 of 60 patients who were considered unresectable or metastatic underwent surgery following conversion. Interestingly, 8 of those 12 patients actually had intrahepatic cholangiocarcinoma. This regimen was so promising that it was then expanded to a phase 3 trial, comparing to the standard of care, which was Gem-Cis. Unfortunately, the trial was not statistically significant for benefit because the overall survival was 14 months in the combination chemotherapy arm, and the Gem-Cis control arm was 12.7 months. However, if you actually look and break down the subgroups, you can see that there appeared to be a significant benefit in the locally advanced population, where the survival with the Gem-Cis nab-paclitaxel was 19.2 months versus 13.7 months with the Gem-Cis. With this in mind, my colleague, Dr. Mathel from Emory, put together this first trial for neoadjuvant chemotherapy for high-risk intrahepatic cholangiocarcinoma. So these were patients that we deemed high risk by those features below, which was solitary lesion greater than 5, multifocal or satellite tumors in the same lobe, presence of major vascular invasion, and suspicious lymph nodes. So this trial accrued in approximately 2.5 years, and we recently published their results. So you can see out of 30 patients that were, 37 patients that were screened, 30 were ultimately enrolled, and 22 underwent the full regimen of chemotherapy and surgery, which was the primary endpoint. So you can see basically a partial response rate in the waterfall plot there, as well as a disease control rate of at least 90%. More importantly, you can see the perioperative outcomes were not changed by the chemotherapy. So the length of stay was still 4 days. There were 2 postoperative complications, and this is despite patients that had, again, these high-risk features. When we actually look at survival, the overall survival has still not been reached, but this was not a focus of the study. You can see on the right some of the pathologic data that included what adjuvant regimens they received, which was left to the investigator. We did have next-generation sequencing in 19 patients, or 63%, of which 6 were actionable, that meaning they either had IDH1 or FGFR2 mutations. We took this information, and then one of my fellows, Dr. Washington, actually looked at what the mutational landscape is in our resectable and locally advanced patients. And so you'll see that in 79 patients over a 10-year period, you can see the distribution, which included BRAF, BAP1, ARID1A, PBRM1. And of those patients that we studied, at least in this small cohort, ARID1 appeared to have a better prognosis, whereas CDKN2A had a worse prognosis, very similar to the Sloan Kettering study. Interestingly, this Korean study that was also recently published, looking at the ARID1 pathway, which is part of the SWE-SNF complex, actually demonstrated a resistance to Gem-Cis. in this population. And you can see on the graph there that the wild type seemed to do better than the mutated ARID1. And interestingly, in the CLARITY trial, which was a phase 3 trial looking at ivosidenib in the advanced population, the IDH1 and ARID1 mutations were found together in about 15% of patients. Of course, the new standard of care, as we know, is the TOPAZ-1, which looked at the, again, standard of care of gemcis at the time versus the combination of gemcis and durvalumab, which is the new immunotherapy. And you can certainly see here by the primary endpoint that there was a statistically significant benefit in the overall survival. Of course, then this was recently then followed up by the Keynote 966 trial, again looking at a combination of chemotherapy with gemcis as well as pembrolizumab, which is again an immunotherapy agent. So we are now trying to use these new regimens in the preoperative setting. And so now we look at, there's several single institution trials, a couple being led by Dr. Tran Kao at MD Anderson, as well as UAB, and then my colleague, Dr. Mathel. Anecdotally, we've tried to use these regimens in the preoperative setting. So this is our experience at OHSU. This was 4 patients who either had microsatellite instability or a high tumor mutation burden. And you can see on the right an example of one patient with Lynch syndrome who was MSI high, presented with a large right-sided liver lesion. And after 12 cycles of pembrolizumab, you can see the conversion of the tumor in the response. And this patient underwent a right hepatectomy without complications and is currently in observation. At the bottom, you'll see a different patient that had a large intrahepatic cholangiocarcinoma and a cirrhotic liver, and he had a high tumor mutation burden as well as an ERBB3 mutation. So he underwent gemcis durva preoperative therapy, and this is the resected specimen showing just 2 millimeters of viable tumor. Again, highlighting the need to get mutational analysis in these patients. Of course, I wouldn't be complete without talking about transplant. So liver transplant for intrahepatic cholangiocarcinoma is becoming more accepted, although it's still considered experimental. This was the initial study that Dr. Lunsford put out from Houston Methodist, looking at, again, patients with unresectable disease who had neoadjuvant chemotherapy and disease stability for at least 6 months. This first 6 patients seem to have reasonable outcomes after transplant with a handful of recurrences, but really prolonged survival. What was most interesting is their follow-up study, where they actually now looked at 18 patients that had liver transplant, 32 of which were listed. And you can see out of the protocol there why patients fell out. But in the patients that did receive a transplant, you can see the benefit of the genetic mutation. So in the liver explant, 27% of these patients had an FGFR mutation, which again, we think might be more favorable. Whereas the minority had P53 or KRAS, those high-risk mutations. So again, there was some biologic selection that was happening inadvertently through the liver transplant protocol. I want to finish by just highlighting a case. This is a case of mine of a 70-year-old patient who had a history of a metastatic sarcoma and then presented with a large liver mass. This was biopsied and confirmed to be a cholangiocarcinoma, not a sarcoma. And due to its size, was started on neoadjuvant GAP therapy, but progressed. When we then did the mutational analysis, she turned out to have both an IDH1 and ARID1A mutation. And so she was switched to the second-line targeted agent of ivosidenib and had lobar Y90 for both tumor control and liver hypertrophy. Ultimately, she ended up having stability of disease and her liver grew, so she was able to have a right hepatectomy and a portal lymphadenectomy. She's currently on surveillance with no evidence of disease. So again, this highlights the importance of getting not only preoperative therapy, but also mutational analysis to guide that therapy. So I think in summary, cholangiocarcinoma has a rich mutational landscape that's currently only being examined in the advanced setting. I do think liver-directed therapy in combination with novel systemic agents like GAP and GCD, targeted therapies like IDH1 inhibitors and FGFR2 inhibitors, or immunotherapy may yield promise for this localized unresectable population, or to downstage patients for surgery or transplant. Therefore, I really advocate for profiling in early stage disease to examine the role of these mutations in the prognosis, the perioperative setting, or to guide the treatment sequencing. As a surgeon, I will always be willing to be more aggressive with more active agents that are less toxic in patients that have favorable biology. I'd like to just say thank you again for the opportunity. Hopefully be available for the question session at the end.